Today on Derm School, let us take a look at common viral infections affecting the skin. We will look at 4 conditions: varicella zoster, herpes simplex, warts, and molluscum contagiosum. Varicella zoster. Varicella zoster virus, VZV, is a type of herpes virus. 90% occur in children less than 10 years of age. Transmission is through airborne droplets and direct contact. Patients are contagious several days before the rash and until the last crop of vesicles. The virus enters through the mucosa of the upper respiratory tract and oropharynx. There is then local replication, followed by primary viremia, then replication in cells of the reticular endothelial system. This leads to secondary viremia and lastly dissemination to the skin and mucous membranes. In terms of the vesicular lesions, it is characterized by successive crops and evolves over 8 to 12 hours from papules to vesicles with surrounding erythema, pustules, and then crusted erosions. And this condition is polymorphic. Crusted erosions heal in 1 to 3 weeks with a pink depressed base and leaving punched out permanent scars. Distribution of varicella is on the face and scalp, moving to the trunk and extremities, but mostly the lesions are on the trunk and face. For the mucous membranes, lesions are most common on the palate. Other clinical manifestations include VZV pneumonitis, which can occur in adolescents and adults, central nervous system, resulting in cerebellar ataxia and encephalitis, and malignant varicella can occur in the immunocompromised with pneumonitis, hepatitis, encephalitis, DIVC, and purpura fulminans. This is a picture illustrating varicella or chickenpox. Complications include secondary bacterial infection in patients less than 5 years old, varicella encephalitis 5 to 11 years old, Bray syndrome 5 to 11 years old, and if the mother is pregnant and the fetus develops varicella, they can get fetal varicella syndrome, in which the baby has limb hypoplasia, eye and brain damage, and skin lesions. In immunocompromised patients, they can develop hepatitis, encephalitis, and hemorrhagic complications. Treatment. Prevention is by immunization. Symptomatic treatment with antihistamines and lotions may be beneficial, and you can consider the use of antiviral agents like acyclovir, valacyclovir, and foscarnet, especially early in the course of the disease. Now, how does herpes zoster occur? During varicella, the virus passes from the skin or mucosa via the sensory fibers to the sensory ganglia. This causes a lifelong latent infection in the ganglia. Reactivation can be triggered by immunosuppression, trauma, tumor, and irradiation. The virus multiplies and spreads centrifugally down the sensory nerve to the skin or mucosa, resulting in vesicles. So these are the different clinical stages of herpes zoster. During the prodrome, patients develop pain, tenderness, paresthesia, and allodynia in the dermatome with flu-like symptoms. Next, you have active infection leading to dermatomal lesions. First, you have papules over 24 hours, leading to vesicles or bullae over 48 hours, pustules at 96 hours, and crust 7 to 10 days, resolving in 2 to 4 weeks, leaving scars which can be necrotic. They can also have lymphadenopathy, which is tender, sensory defects and mild motor paralysis, as well as flu-like symptoms. And the third stage is post-herpetic neuralgia, and if this occurs, you can have constant severe stabbing or burning, dysesthetic pain. This can last months to years and can even cause depression. So this is a picture of the dermatomal involvement with vesicles in herpes zoster. Ophthalmic zoster can also occur, and this happens when you have nasociliary involvement of the V1 ophthalmic branch of the trigeminal nerve. And in this condition, patients have vesicles on the side and tip of the nose, which is known as Hutchinson's sign. There are many complications resulting from ophthalmic zoster, including uveitis, keratitis, conjunctivitis, retinitis, optic neuritis, glaucoma, proptosis, cicatricial lid retraction, extraocular muscle palsies, or even acute retinal necrosis. So these patients need to be seen by an ophthalmologist. This is a picture of a patient with eyelid herpes zoster ophthalmicus. Now, complications of zoster include dissemination in immunocompromised patients, so it can involve more than one dermatome for these patients. Neurologic complications including meningoencephalitis, cerebral vascular syndromes, cranial nerve syndromes such as herpes zoster ophthalmicus or Ramsay-Hunt syndrome, peripheral motor weakness, transverse myelitis. Visceral involvement including pneumonitis, hepatitis, pericarditis or myocarditis, pancreatitis, esophagitis, enterocolitis, cystitis, and synovitis, as well as post-herpetic neuralgia, as we have discussed. Treatment. Prevention is by vaccination. You can consider using antiviral therapy such as acyclovir, valacyclovir, famciclovir, and IV foscarnet. Supportive treatment including bed rest, sedation, analgesia, and moist dressings. And the treatment of post-herpetic neuralgia includes gabapentin or pregabalin, tricyclic antidepressants like doxepin, topical capsaicin cream, and nerve blocks. We now move on to the second topic, which is herpes simplex. This is caused by HSV1 and HSV2. HSV1 is mostly associated with herpes labialis, while HSV2 urogenital. Transmission is skin to mucosa, or mucosa to skin, and most commonly affecting young adults. Factors for recurrence include irritation such as from UV radiation, menstruation, fever, common cold, immunosuppression, and the site, including genitals. Pathogenesis of herpes simplex. In primary infection, this is due to close contact with the person shedding the virus. There is then inoculation onto the mucosal surface or break in the skin. The virus replicates in epithelial cells, leading to lysis, vesicles, and local inflammation, and the primary infection can be symptomatic or asymptomatic. Next, the HSV ascends your peripheral sensory nerves to enter the sensory or autonomic nerve root ganglia and leads to latency. You then can develop reactivation where the virus particles travel along the sensory neurons to the skin and mucosa, leading to recurrent episodes of herpes simplex. Primary HSV infection can be asymptomatic. In symptomatic cases, patients present with vesicles at the site of inoculation. These start as papules leading to vesicles or pustules and lastly erosions with or without tender regional lymphadenopathy and systemic symptoms, including fever, headache, malaise, and myalgia. In children, they can have primary hepatic gingival stomatitis. In young women, primary hepatic vulvovaginitis. And sites of primary HSV infection are the mouth, anal genitalia, or hands or fingers. The primary infection heals in 2 to 4 weeks with post-inflammatory hypo or hyperpigmentation with or without some scarring. In primary hepatic gingival stomatitis, this involves the oral mucosa or oropharynx, and the patients can have perioral facial involvement. There are vesicles and then erosions, which can be scanty to numerous. The patients may also complain of gingival erythema, edema, and tenderness, and the pain can be severe. In recurrent herpes, there's often a prodrome which starts 24 hours prior with tingling, itching, and burning. They then develop grouped vesicles on an erythematous base, leading to erosions and crusts. Rarely this is intraoral, and they usually don't have systemic symptoms. For trigeminal nerve infection, this can be due to your perioral infection or cold sores. You can also have ocular infections with recurrent keratitis leading to corneal scarring, and this requires suppression therapy. Herpetic facial paralysis can occur, known as Bell's palsy. And herpes gladiatorum is due to contact spots and also can involve your cervical or lumbosacral dermatomes. Herpetic folliculitis presents as follicular vesicles and crusts. It is also known as viral psychosis when it's involving the beard area of men. In involvement of the cervical and thoracic sensory nerves, herpetic whitlow refers to involvement of the tip of finger, thumb, or toe and can result in painful neuritis on the finger and forearm. HSV infection of the nipple can occur if it's transmitted from the infant to mother during breastfeeding. And HSV infections of the lumbosacral sensory nerves results in vesicles on your genitalia, buttocks, thighs, and perianal mucosa. This is a picture of herpes labialis. Complications or other manifestations of herpes simplex include eczema herpeticum, Staphylococcus aureus secondary infection, erythema multiforme, which occurs later, and aseptic meningitis. For genital herpes, primary infection is very similar to what we discussed previously, and they can also present with enlarged tender inguinal or femoral lymph nodes. In recurrent genital herpes, the symptoms are itch, burning, fissure, redness, irritation, dysuria, sciatica, or rectal discomfort. The patients have 1 to 2 centimeter in size erythematous plaque with vesicles, and these rupture with erosions. In anorectal herpes, the patients present with tenesmus, anal pain, proctitis, discharge, as well as ulcerations. Treatment of herpes simplex. For prevention, avoid skin-to-skin contact. Topical antivirals have minimal efficacy, but agents include acyclovir or penciclovir for recurrent oral labial disease. Oral antivirals include acyclovir, valacyclovir, and famciclovir. For genital herpes in immunocompromised patients, think about IV or oral acyclovir. In patients who are resistant to acyclovir, you need to administer IV foscarnet. We will now look at warts. Warts are caused by human papillomavirus, HPV, and it is due to skin-to-skin contact. In patients with immunodeficiency, warts are more common and widespread. We first look at the common wart or verruca vulgaris. These are firm papules measuring between 1 to 10 millimeter and are often hyperkeratotic with clefted surface and vegetations. The presence of red or brown dots are characteristic of warts, and these are due to thrombosed dermal papillary loops. Common warts can be isolated or scattered discrete lesions. On the palms, they disrupt the normal lines, similarly with the soles. Warts can also be filiform, and they often affect sites of trauma such as the hand, fingers, knees. These are a few variants of warts. Plantar warts occur on the soles and are also known as verruca plantaris. First, there's a papule and can even become a plaque, and once again, there are disrupted lines on the soles. Mosaic warts are due to confluent warts. You can also develop flat or plain warts, verruca plana. Butcher's warts are due to HPV7, and there is a genetic condition called epidermal dysplasia verruciformis, which is autosomal recessive, in which the warts are papules or pityriasis versicolor-like lesions. You can also have oropharyngeal disease and anogenital warts, which are small papillar warts. If they become cauliflower-like, they are known as condyloma acuminatum. Anogenital warts can also be keratotic or flat-top papules or plaques. On the left, you have a picture of common warts, in the middle, filiform warts, and in the last picture, you can appreciate the presence of plain warts. Treatment of warts is with imiquimod cream, cryosurgery, electrosurgery, laser, surgery, HPV vaccination, and intralesional pseudophobia or candida. Treatment of genital warts include imiquimod cream, podophyllin, trichloroacetic acid, cryosurgery, electrodesiccation, surgery, and intralesional pseudophobia. The last condition we'll look at today is molluscum contagiosum. And this is caused by the molluscum contagiosum virus, MCV. It is transmitted by skin-to-skin contact and often seen in children, as well as sometimes in sexually active adults. In advanced HIV, they have more severe disease in which there are hundreds of small mollusca or giant mollusca. These are the clinical manifestations of molluscum contagiosum. You have papules, nodules, or tumors with central umbilication or depression, as you can appreciate in the photograph. The lesions are skin-colored and round, oval, or hemispherical in shape. They can be single, multiple, or confluent. In larger lesions, you will see a central keratotic plaque, and they can resolve with post-inflammatory hyperpigmentation. Distribution, it can occur on any site, especially on naturally occluded sites such as the axilla, cubital fossa, popliteal fossa, and the anogenital areas. In atopic dermatitis, lesions can be widespread. For sexually transmitted molluscum, these are found on the groins, genitalia, thighs, and lower abdomen. In immunosuppressed patients, they can develop multiple facial molluscum, and the molluscum can also arise on your conjunctiva. So treatment can be divided into physical and medical. So the basic principle is to try and destroy the lesion. So for physical, you can remove the core physically, use cryotherapy, curettage, electrodesiccation, as well as laser. For medical treatments, these include antiseptics, podophylotoxin cream, salicylic acid, cantharidin solution, adapalene gel, which is very useful for children, trichloroacetic acid, which is an in-office procedure, as well as berdazimer gel. Prognosis of molluscum, usually it regresses around 6 months with no scarring. However, in patients with HIV, the molluscum contagiosum can persist and proliferate. And so with that, I thank you for your kind attention and hope you found this useful. Have a great day.